And we're ready to go.
Great. Okay, so it's 12:15 and we're going to begin our program. So this is Barry Sarvette. I'm the statewide medical director for MCPAP, and I wanted to take the opportunity to welcome everyone to our Clinical Conversations program, which, as you know, takes place on the third Tuesday of every month. The topic for today, we're really excited about it, is early childhood behavioral health and two-generation approaches. Before we begin, I just want to mention a few housekeeping issues. First of all, the session will be recorded, and it's available on the MCPAP website at www.mcpap.com. So please share this with your friends and colleagues. A copy of the slides will be available on the MCPAP website under the Toolkits and Resources page under PowerPoint presentations. We have presenters today who will be happy to answer questions. So just use the question function at the bottom of your screen or raise your hand, and we can try to bring this to the attention of the presenters, and they can take your questions. Please type into the question box during the presentation. We will read out your question or unmute your line so that you can ask it yourself. At the very end, you'll receive a very brief survey, and we really appreciate it if you could answer the questions to help us to improve our future presentations. So today's presenters are Doctors Martha Vibbert and Alyssa Orenstein-King from the Spark Center at Boston Medical Center. Dr. Vibbert is the executive director of the Spark Center, and she holds faculty appointments in psychiatry and pediatrics at the Boston University School of Medicine. She is also a core faculty member of the Center for Multicultural Training in Psychology at BMC. Dr. Vibbert is a licensed clinical psychologist whose research is focused on early language acquisition, early parent-child interaction, and the combined impacts of health problems, poverty, and caregiving environments on early neurodevelopment. Her clinical work focuses on developing models of care that integrate mental health care into pediatric and early childhood education settings with the goal of supporting vulnerable families and helping young children to cope with early trauma, developmental challenges, and chronic illness. She's the co-founder and director of Universal Baby, an international video and mobile technology intervention to promote key reciprocal parent-child interactions that nurture infant brain development and strong early attachments. Dr. Alyssa Orenstein-King is a licensed psychologist specializing in early childhood. She is the director of mental health services at the Spark Center at BMC, which is a pediatric child care center and outpatient clinic for young children. She specializes in providing trauma-informed dyadic therapy, including PCIT, which is parent-child interaction therapy, to young children and their caregivers. Dr. King also provides comprehensive developmental and psychological evaluations for young children. She trains psychology and mental health trainees to consider developmental, cultural, and psychological domains when assessing and treating young children and their families. So I'm going to turn it over to our speakers, and thank you so much for joining us.
Thank you, everybody. This is Dr. Vibbert. I'm delighted to be with you. And we're expecting Dr. King to join us probably in about 10 minutes. She was just finishing up with a family, but she said she'd be on by 12:30. So we'll keep our fingers crossed. It's really a pleasure to speak with our colleagues in pediatrics and to think together about how integrated behavioral health for early childhood can really function at its best to help providers across a lot of different domains think in complex ways about young children, their family context, their developmental needs, and their futures as, future ability to thrive. So we'd love to focus today a little bit on two-generation approaches that we are using increasingly here at Boston Medical Center, and to give you a sense of the context in which we work. I think I heard Alyssa join. Are you there, Alyssa?
I am. Can you hear me?
Yes, I can. I hope everybody else can.
Okay, great.
We're good to go.
All right. So, great timing. So, a little overview of what we hope to accomplish today, give you a context of our work. We'll be using some de-identified case examples to enhance the conversation. We'd love to touch on some of the main causes of concern that our primary care colleagues tend to deal with on a daily basis, some considerations when making hypotheses and referrals. We hope to convince you about why quality assessment matters, give a brief introduction to these two-generation dyadic treatments that we find so promising here at Spark, how to think about accessing consultation and follow-up, and most importantly, to hear from you about your questions, comments, and needs going forward. So this is the Spark Center. We're a community child development center at Boston Medical Center. We've been in existence since the late 80s. We originally started as a response to the pediatric HIV epidemic in Boston, but since then have branched out to provide a whole range of services for young children, and to be specific, infant, toddler, and preschool age groups. We operate an early education and care program, a center-based specialized child care program for a small group of children on a daily basis. That's about 15 children at the present time. We host early intervention colleagues here who deliver their care pretty routinely on site in order to get consistent access to children, and they combine that obviously with home visits. We partner with Boston Children's Early Intervention Program, and that program is known as Sparkles. We do a lot of teaching and training, and primarily focus our efforts with early childhood psychologists and early educators, and some international work to support the growing concern about early childhood development and how to encourage it in different cultures and different contexts across the globe. But we're here today to tell you about our pediatric behavioral health care service, which is an outpatient service covering these areas that are listed here. Interestingly, we're located in Mattapan on the BMC campus on River Street. And this gives us a unique opportunity to do some fairly non-traditional and unconventional ways of delivering care that in ways that we hope are responsive to families' needs. Parking at the hospital is expensive. It can be very stressful for young families to go to the hospital. And so this offers a nice alternative in a child-friendly setting. So we tried to generate a list, and it's not a complete one, of some of the presenting issues that you may be encountering in your primary care settings. And we think of them kind of in three different buckets, although you may want to add other buckets. Biodysregulation, which is, persistent and hard to explain. And these are some of the areas: sleep, feeding, elimination, energy levels. We probably should have added attention there. Also, the child who's emotionally dysregulated with a great degree of lability and an inability to self-soothe, and the absence of or poor relational capacity. Out of control behaviors are probably pretty dramatic when they occur in the primary care setting and hard to miss. And then sometimes anxiety issues, which can present with obvious behavioral expression, like severe clinging behavior or obvious difficulties with separation and high degree of distress and fear, or even phobic responses. But sometimes it can be more subtle. Shyness is kind of inherent in the primary care visit. Children will feel inhibited. So sometimes we're relying parental report to pick up some of these issues. Alyssa, do you want to add anything at this point?
I think good so far.
Okay, keep moving through. So we have plenty of time for questions. So when you think about what is happening and why, sort of the conceptualization behind the behavioral presentation, I think probably we would all agree that there are certain categories that make sense. So obviously a developmental problem. We're on the lookout for something that has an environmental cause, perhaps some kind of traumatic exposure. Maybe it's a physiological problem, and that's probably the first go-to for our medical colleagues to think about. And then obviously environmental factors, the psychosocial stresses that are part and parcel of young children's lives and families' lives, increasingly with the pressure on families to have two jobs and sometimes dealing with housing that is unstable or food insecurity, things we're alert to in our settings. But as we thought about those sort of rock bottom causes for the kind of behavior children express, we also found ourselves continually coming back to the parent-child interaction, and more specifically the attachment and connection between parents and children, which really is the lens through which everything occurs. We wanted to encourage our use of curiosity and our own self-reflection in the exam room to think about what impact is this child having on the parenting dynamics, what impact is the child having on our own experience in the room. So that's where self-reflection is a very helpful tool. We want to basically encourage the muscle to think dyadically, think about the attachment between the parent and the child when we're considering these issues and these problems, and to be alert to signs in the parent-child interaction that often offer very valuable clues to our diagnostic thinking. So what can we observe and sort of query about the parent-child relationship that might enhance our early hypothesis making? And I'm sure that everybody on this call has had a tremendous amount of training in this area and is looking at everything in that exam room, but we thought we might list some of the key interaction elements that psychologists think about when they code, for example, parent-child interaction behavior. Some of the dimensions can be quite subtle, some are more obvious. And so we wanted to share some of the things that come to mind for us. So obviously, parent responsivity. Is this a dyad that is interacting with each other? And that doesn't mean it has to be in words. It can be as subtle as joint attention, vocalizations. Are they able to attend to a joint topic together, even if it's the joint topic is you as the provider? Child-directed speech, or child-directed vocalizations, another very interesting way of gauging sort of the level of interaction between the dyad and even the quality of attachment. Eye contact, social bids, is the child seeking comfort. Signs of affection, we know that affection and nurturing behaviors and shared enjoyment are key elements of healthy early interaction. Granted, they may not be as obvious in an exam room, but on the other hand, if a child's distressed because a shot is coming or they're nervous about your white coat, it's very important to see if there can be breakthrough signs of affection between parent and child. And is it all distress related, or can it be, is there a range of behavior in that domain? And you can read some of these other questions or comments that come to mind for us. Maybe give a pause here for people to read and think if they have any questions, or Alyssa, if you want to add.
I think we just want to also highlight the importance of attending to the parent or caregiver's affect and the way in which they talk about the child. So, are they using positive words? Are they using negative words? A combination. Obviously, if a child's having behavioral issues, we're going to hear some negative pieces there, but Are they able to also reflect on the positive, share some positive things about their kid, or is it all really focused on the negative? Because that, becomes a sign that there's something really problematic in that relationship. And it may be coming from, the child, coming from the parent, really, but what we're seeing is there's something not working in that relationship. And that's going to be important, whether or not the parent's accurately reporting a problems in the behavior, whether or not, it really doesn't matter. What matters is that the parent is having a negative experience of that child, and that's going to impact the way that they're able to parent that child. And so we just want to make sure that we're attending to that piece as well. So, if the parent is concerned, even if what they're reporting isn't actually concerning, they have concerns about, behavior that you're like, oh, that's typical for a 2-year-old. But if the parent can't kind of place that within context and kind of see the bigger picture, then that's still notable that something isn't really working and that we may need to think about ways to intervene.
And when we're thinking dyadically too, we're of course paying attention to the parent's affect. Do they look depressed? Do they seem down? Do they feel hopeless? And Ever Alert now, because of the increasing body of research on adverse childhood experiences and the impact they may have on our parenting behaviors, more and more clinicians now are thinking about trauma, and they're thinking about the questions that we don't typically ask in a pediatric visit, but that may be lurking in the air. So if a parent is experiencing trauma, if the family has experienced a trauma, and trauma could be, it could be fairly benign in the sense of, a recent abrupt change in housing or caregiving, which is not benign for a child, or it could be that there's active domestic violence in the home. Is parents, struggling with a substance use disorder? These are questions to be alert to, and if you don't have screening instruments in the office to kind of sort of tickle those responses, it is definitely worth considering some questions that you can have up your sleeve to open discussion around those areas. Obvious red flags: if a parent is engaging in a lot of self-blaming statements, even, sometimes a parent will make a joke, a very sarcastic or sardonic joke. We take those seriously as a sign sometimes of help, a way that's maybe experienced as safer for a parent to ask for help. Obviously, attribution of malevolent intent to a child is always concerning, and a parent who's remote and disengaged with their child is a sign for concern. I guess we want to emphasize that everything needs to be in the context of culture, of an appreciation of varying child-rearing traditions, of honest interest in a parent's or family's belief systems about child-rearing. Does the parent have knowledge of child development? Are we working with a parent who's Googling everything, or are we talking about a parent who may not have had access to any information about child development before this child? And obviously socioeconomic and environmental factors. We want to use language that's strength-based, that's neurodevelopmentally informed. There is so much more that we know now about how babies' brains develop and the factors that influence that, and we shouldn't be shy about sharing that. We like to say, when we meet new families, we're learning a great deal in the child development literature, in neuroscience, about the young baby's brain, and parents are increasingly concerned about how to be promoting that development earlier and earlier in their child's life. And we're always focused on the future, helping the parents to understand that the way they think about their child's problems now and the help that they seek to improve the quality of their interactions or the quality of their child's functioning is laying huge building blocks for that child's future. And I think most parents can understand that. Whereas that used to be kind of a grandmother thing to say, now we have real hard science to back that up. So it's good to be able to reinforce that when we're talking to a parent. Cautions. It takes trust, safety, listening, patience, and respect for parents to feel comfortable revealing themselves. And it's a tall order in a quick pediatric visit. We know that. And so this is where I think, the team approach, having people on the team who can provide that sense of safety in the room. Sometimes it can be including a social worker right in your exam room so that the family feels safer if they've had earlier conversation with that provider or the nurse, and demonstrating your willingness to take the time to listen and to solicit the kind of material that we're talking about. Inclusive openers, that's desensitizing language to help parents open up. When we normalize conversation about attachment or psychological phenomena, we might use language like, so many of my patients are telling us that they're finding it difficult to do X, Y, and Z given the influence of all the different stressors in their lives. So that's an inclusive opener that makes it safer for a parent to bring up some of these issues that may feel sensitive to them. Trying to prevent premature categorization in our thinking, I think, is a real challenge particularly when you're seeing the 8th patient of the day, or you've had, a lot of experience with one particular behavioral presentation. Maybe it's ADHD, maybe it's sleep disorder in a young child, but there's always more to it. There's always more. And to the extent that we can open up conversation about the context of these behaviors, about parents' ideas about the behavior, the better we're going to be able to come up with, effective treatment. So we are routinely trying to resist sort of the automatic referral path or the idea that medication is a quick fix and can get this thing working on track, when really it might make more sense to invest in referral for a therapeutic intervention before thinking about even ADHD medication. Do you want to pick up here, Alyssa, since we're going to move into the assessment part of this?
Sure. Yeah. So I think that, dovetailing on what Martha was saying, that I think what's really important, particularly in younger children, but for any kid, that before we're going straight for medication of any kind, or even kind of figuring out what kind of intervention is needed, I think we really need to understand what is going on conceptually. Maybe that's diagnostically, maybe not, depending on the situation. There may be a specific diagnosis, maybe not, but I think that's where, going back to one of our earlier slides, when we're thinking about, what might be contributing to a child's presentation, particularly in young children, we need to think about all of those different areas. And that's where comprehensive evaluation can be really important. So things like a detailed diagnostic interview, which may or may not be possible in a primary care setting, where you really get, all of the details of the child's history, which probably, would be had in a primary care office, but also really, really detailed explanations of whatever is causing concern. What are the environments where it's occurring? Does it look different for different people? When did it start? Has it changed over time? Really trying to nail down all of those details, because that gives us a lot of information. more comprehensive information about developmental history to try to figure out whether or not development is on track. And if it's not, I think that that's another area where, more comprehensive evaluation is important. Is the child delayed in language, and that's why they're tantruming, because they're so frustrated because they can't get things across? Are they struggling socially because they can't communicate with their peers, and their play skills are also delayed, which makes it harder? Could it be something like autism that, of course, is going to interfere and may be associated with, all the other problems that we know? So, further evaluation of development might be appropriate, using some structured testing that, psychologists specialize in doing. Really observing the parent-child interaction, which of course can be done in a primary care office, although for young kids, we know that doctors' offices don't necessarily pull, what their typical behavior might be for a variety of different reasons. So sometimes being able to get information about that interaction in other kind of environments may be helpful. Using play, how does the parent play with the child? Does the parent play with the child? What does that play look like? How does the child respond? Is the child able to follow some basic direction and command as necessary? Those types of things. And then all of the other, positive things we'd be looking for. Is there that shared enjoyment, the attunement? Is the parent responsive to those cues? All of those types of pieces that you get a flavor of in the primary care office, but you may not get the full extent of it, just related to the environment that it is. Really, if possible, I talked about kind of really getting the details about the behaviors, but if you can actually see it, if there's ways, which you may see in the primary care office, but really trying to figure out kind of what led up, what are the triggers, what are the environmental factors that we may or may not be able to control, and then what are the responses to that behavior, and is there ways in which the parental response to that behavior is actually reinforcing it in some way and making it more likely to continue. So that's, and it also helps us figure out what's the function of the behavior. I mean, in a primary care office, you maybe see a lot of the avoidance and escape behaviors, particularly if there's shots or other things that the child doesn't want, but you could also see other functions of behaviors as well. So really trying to figure out the function. That would be the FBA, functional behavior assessment. And then, sometimes using standardized rating scales can be helpful from both the parents and teachers. If the child is in school, that can be, or even a daycare, that can be really helpful to get a sense of what the behaviors are like in different environments and comparing it to other kids in that age range. So, we view this as, potentially really important to really try to understand, because there's so many different factors that come into play, and we really want to differentiate. Is the developmental issue there? Are there environmental stressors, trauma going on? Is it something more purely, behavioral from the child, something like ADHD, or is it a combination of all of these? And often it is a combination of at least some. So really trying to figure out, what is going on, and then what is our best port of entry? So where are we going to intervene? And some of that is really going to depend. And, not necessarily only intervening in one way. We may have to address all of it. So if a child truly has ADHD, which they might, medication could potentially be appropriate, but that's not going to affect, that doesn't solve necessarily the challenges in the parent-child dynamic, or the parent's knowledge of how they can best support their child, if they have a diagnosis of ADHD and some of the difficulties associated with that. So that's where some of those dyadic interventions can still be really important, regardless of what the ultimate conceptualization or diagnosis might be.
And just a reminder too that, if a child presents with, for example, a developmental issue, say it's language delay, and, we get early intervention in place as sort of the first line treatment, it's useful to remember that and this is very much what Alyssa was saying, may address that developmental issue in a quite focused way, but not necessarily the other problems that may be related to the fact that the child's not communicating well, or that may not even be related at all to the developmental problem. One example of a recent case we've been treating here at Spark of a young child, I think about 16 months, with obvious expressive language delay, some motor delay, slow in getting up on her feet and cruising. Very concerning from a developmental standpoint, but equally concerning are the behaviors that have evolved, the repertoire of behaviors that have evolved to compensate for that expressive language delay, that are quite problematic for the attachment, in the sense that the child's not able to sleep through the night, waking up 3 and 4 times to want to cuddle with the parent, unable to get down off the parent's lap, or separating even the most simple ways from the parent. So that was a case where, plugging in early intervention was just the first step to really doing a fairly intensive deconstruction with the family about the behaviors that we're reinforcing, what is already likely a child with, innate shy temperament, working out the family history to confirm that, to rule out other neuro complications, and a piece of work that was really far more comprehensive than the original developmental delay that got it started. So just to make the point that this 2-generation approach, where you're really treating 3 patients, the therapist is working obviously with the child, the parent, but really zeroing in on the relationship and what's working well and what could be strengthened. And the therapies that have really grown out of the last maybe 5 to 10 years, and really bolstered by quite a strong evidence base now, that we're going to share with you quickly in the next slide, have shown to be effective for many early childhood behavioral and emotional problems. Obviously, some of them have been started in the context of early trauma, children of abuse or exposure to domestic violence, but they have, and also children with, obvious behavioral control issues, but they have also been found to be effective for children with medical trauma, for example, children who are having repeat procedures related to a chronic illness or to a surgery, even children who have gone through caregiver disruptions, a population we see a great deal here at the Spark Center, where a child may be moving from one home to another in the foster care system. Grief reactions, we have found that this approach, where you're working with child, parent, and the combination of the two in the therapy space, very effective for these kind of events in families' lives that can really derail early development if they're not attended to carefully. So some examples, some of you may have heard of these various approaches: parent-child interaction therapy, which Alyssa mentioned, and some of the others here that are well known, child-parent psychotherapy. These are quality-assured interventions. They require a great deal of intensive training that mental health professionals go through, not only classroom-based, but also collaborative supervision of casework over a long period of time. Trauma-informed cognitive behavioral therapy, an approach that's been used very effectively for children who have had quite discrete and significant trauma events. A new intervention that we're very fond of and busy trying to learn here at the Spark Center, called the GABI, the Group Attachment-Based Intervention. This is designed for caregivers and very young children, babies under the age of 2, working in a group. And it incorporates some separation and reunion events that help clinicians to really get at the core of what parental anxieties may be operating to sustain interactions that aren't as helpful to the child. So you're really trying to understand a little bit more about the parent's internal monologue about their own parenting and how we can strengthen that to be more positive and more hopeful. Other approaches that are out there, there's a million of them. We just picked a few here that work focused very much on the parent's own experience. Circle of Security, Parenting Journey are two well-known versions of this. And then something we're very interested in which is videotape use and how to use that in a therapeutic way to nurture development. The FIND interventions has received a lot of attention. You can find it on the Harvard Center for the Developing Child website. And we've developed our own process here called Universal Baby, which is an effort to get moms and children, and I say moms, but it can be obviously fathers, grandmothers, even an older sibling who's caregiving for a child, to get that interaction on videotape so that we can share it in settings where we want to customize the cultural language approach to reach a lot of different audiences of caregivers across the globe. Anything you want to add here, Alyssa?
I think you covered it.
Okay, that's just to whet your appetite and hopefully to set us up for a good discussion. I think we as behavioral health care providers really want you to know that we appreciate the frontline work that you do to understand or to get clues about what you're seeing in the interaction and what you're seeing in child behavior and parenting behavior. And the power really is in your hands when you make that referral. If you are able to make it in a way that reduces stigma for access to mental health, that helps a parent feel less vulnerable, that opens up this material to intervention in a way that's normalizing rather than shaming or giving the parent a sense that something's so wrong that it can't be fixed, you're really taking a step to reducing the risk of intergenerational transmission of these problems. And you create hope and the expectation for change among vulnerable families. And everything that you do now, even if that baby is only 6 months old, you are setting up a positive trajectory for the family to access mental health care in the future for themselves and for their child, which is something that you really can't overstress how important that is. We want mental health care to be ever more available to families in ways that are accessible and in ways that really create protective momentum for children so that they can thrive. So we thank you and wanted to offer a way to get in touch with each of us if you have questions following up and to share some of the work we're doing here. If you're interested in learning more, coming by for a visit. We love to host visitors at the Spark Center. We have a lot of one-way mirrors and capacity for you to learn more about the work that we're doing, to watch it even if you're interested. And we are increasingly doing trainings across the state, very interested in reaching new audiences. If you have colleagues that you think would be interested in some of what we've talked about today or would like more in-depth look at some of the therapies we've been talking about or the assessment tools that Alyssa covered, we'd be very happy to follow up with you and learn about your needs. So with that, maybe we open up for conversation.
Yeah, just a reminder, to ask questions, you can raise your hand. There's kind of a hand-raising button next to your name in the participants list. Or you could, and then we would unmute you and you can just ask it yourself. Or you can type a question into the question answer section, which is another command at the bottom of your screen. So we'll wait a few minutes and see if people want to ask any questions. And we still have some time because we are scheduled until 1:15. There we go. All right, so Kate Roper asked the following question. Do you use the DC 0 to 5 as part of your assessment protocol? And if so, can you share a little bit about it?
Alyssa, you want to tackle that one?
So I could start on that. So, you know, we certainly do reference that. Unfortunately, as you probably know, we still need to use ICD-10 codes in order to get reimbursed from insurance companies for that. But we certainly will reference the DC 0 to 5 because I think the information included there is kind of more relevant to those younger kids, and they think about the diagnosis in more of a developmental approach. So it's certainly something we incorporate, but we still are trying to map whatever we see onto kind of a DSM-5 or ICD-10 diagnosis as well. I don't know if there were specific things you wanted to know about it, but it's not it's something we will reference. We certainly access it as not our primary tool.
Okay, thank you. So Ellen Perrin asked the question, does Medicaid or commercial insurances pay for the kinds of dual generational work that you guys are describing?
So yes, they do. I think the place where it gets a little bit trickier is for the really young kids, which I know we're not necessarily talking about, like infants. It's a little bit more tricky, and sometimes then we have to determine whether we're going to put it under the parent as kind of the quote-unquote identified patient. But for older kids 2 and up, for sure, we've had no problem having insurance pay for these kinds of services.
And I might add, too, that we currently have a federally funded clinical project here that it gives us a way of providing care without having to bill for third-party reimbursement in some cases, particularly where there's a question of parental exposure to domestic violence, even in their own childhood, or if there's a past history of that in the family may be able to be eligible for this project, and we are focusing particularly on parents and children under the age of 3. And our colleagues at Boston Medical Center, who are also part of this project, are able to see children somewhat older, and that kind of bypasses all the challenges of third-party reimbursement. So wanting folks to know about that and to keep it in mind if you have a family you'd like to refer, and we can screen them and see if we can make it work.
Looks like I know we have a follow-up question, but someone else wanted to respond to it, maybe. I don't know. So I'll just answer before. Does insurance pay even if the child does not have the diagnosis? No. So we have to come up with something, but, I think we can kind of be a little bit flexible with something. I mean, usually there's some sort of behavior problem unspecified we can use, or anxiety unspecified, adjustment disorder unspecified, kinds of diagnoses, things like that, where we can kind of utilize them if there's not, a more specific diagnosis that would apply for that particular child.
Okay, so why don't we stand by for just another minute or two, and there are no other questions that have been raised, and I don't see any hand hand raises.
Also interested in people's thoughts, reactions, areas that you think we may have missed in the way we kind of formulated the talk. It's very helpful for us to get feedback about whether or not there are areas here that are of continuing interest or not.
All right, it looks like we're out of any questions or comments. So I just wanted to thank you guys so much for the talk. I thought it was very interesting. Oh, looks like there's one more. Kate Roper asked, can you describe the challenges in keeping families engaged in treatment?
Sure. I mean, so many. And I think what we've learned over the years at Spark is that we have learned to be flexible in our expectations of families. The idea of a regular hour once a week for a lot of the families we take care of is a fantasy. It's not doable. We get pretty flexible about scheduling times that work for families. We love working in a non-traditional setting, as we mentioned at the beginning, because a parent, we certainly have found that may feel far more comfortable coming to a child development center than to an outpatient traditional medical office for this kind of work. And we've learned that families ebb and flow in their engagement. So what may start out as a three sessions, intense sessions at the beginning, you may take a pause and be able to work that family back into your schedule when they are ready to re-engage again and to go at a slower pace. For some of our work, we're able to use support or assist with transportation from time to time, which can make a big difference.
So there may be another question from someone who started to ask something on the Q&A. So for just another moment. Oh, there it is. So Eric Ruby asked, pediatric residency must stress social determinants of health or put social workers in their offices. And I guess that's a comment.
Yeah.
And it does reflect the policies and practices of that are really supported by the American organization, the AAP, and the Mass chapter, of course, as well. So I certainly, I don't know if you have any thoughts about that that you want to respond to.
I mean, I think that's, statement is right on, that this is very important for pediatricians to be thinking about and how it can be addressed inside the pediatric office, because a lot of times that's the main point of contact, or at least the first point of contact for a lot of these families is their primary care provider for the child. And I think that they're not going to get, it's pretty rare for young kids that they'll go immediately to a psychologist or psychiatrist or other specialists in that area. And so, oftentimes it does fall on the primary care providers to be aware of this and noticing this and getting social workers involved, which is a lot in kind of the practice of of pediatrics when there's short appointments and it's often chaotic and there's a lot to get done and a lot going on. But I think, figuring out how that can all be done in those visits is really important.
Thank you. So there's another question from Sophia Chu. And actually, there are two questions. The first is, what behavioral problems are you seeing more often in households where both parents work? And then the other question is, how do you think social media is affecting parenting in today's day and age?
Those are such important questions. Thank you for bringing this up. I think that, they're related. We could spend a whole hour on each one of these questions, but obviously they're also related. I think, you know, as psychologists who are intensely interested in the nature of parent-child interaction and how it supports early brain development and social development, we're very concerned about the increasing pressure on families when two parents work or they're working alternate schedules. It can be extremely difficult to find those moments of high-quality interaction with your child. And I think we're increasingly trying to find ways, very pragmatic ways, for families to build that in, even under the press of you know, both parents working. And then social media just adds to the challenge, and TV screens and phone screens, which have had the capacity to really hijack young children's attention. They tend to dominate frontal lobe activity, so that children are harder to engage in social interaction when you're competing with the intensity of a high-moving animated screen. So we worry about that a great deal and spend a lot of time, you know, gently trying to help parents think about the impact of TV and screens on their child's cognitive and social development. And parents get a lot of mixed messages. They get all kinds of erroneous messages about how screens help children, when in fact they really have been shown to, the negatives far outweigh the positives in some cases. And so I think that mental health providers, social workers, doctors, nurses can all be kind of sharing the message with families that these are tools that can be wonderful in some respects, but need to be limited and can never supplant the importance of face-to-face interaction between caregivers and their children.
Right, and I think, you know, to add on to that, not only is it impacting the children, but it's impacting the parents. I mean, I think so often now we see parents, you know, on their phones, you know, while their kids are playing. You know, they have the pictures that, you know, they show of parents on the playground, and all the parents are on their phones while their kids are playing. No one's watching what the kids are doing. They're not, you know, engaging in the same kind of play and interaction with their kids because they're caught up in the social media and their phones as well. And so, you know, figuring out ways to, you know, that social media can be really important, you know, for adults. It's a way to stay connected with people, family members, things like that. But that, you know, being in the moment is also really important. So it's modeling for the children as well, you know, having the parents model that, you know, there's a time and a place for electronics, but it's not all the time. And that real world interaction is important as well.
Those are great answers. Thank you very much. So I think we're out of questions. So I just wanted to thank our speakers first and foremost, and thank everyone for being present and participating. If you have other questions, you can email them to mcpap@beaconhealthoptions.com. I do want to remind everyone just to take a moment to fill out the brief survey at the end, and also that you can get the recording on our website according to the instructions I gave in the beginning. But thank you again, and we'll see you next month.
Thank you.
Thanks.
Thank you.